A continuación les quiero presentar a la doctora Anne de Vriese. La doctora de Vriese viene de Bélgica. Ella hizo sus estudios en la Universidad de Ghent, en Bélgica. Después estudió también en posgrado en Alemania y París. Ella es doctora de Medicina. Actualmente es la directora del Departamento de Medicina Interna del Hospital AZ Sint-Jan en Brujas. Y su interés clínico su interés sobre todo en la nefrología clínica, especialmente la diálisis. La doctora de Vriese nos va a dar 3 conferencias. La primera hoy día de diálisis intensiva, frecuente, prolongada y hemodiafiltración online. Mañana y más tarde hablará de vitamina K y calcificaciones vasculares y mañana de los catéteres de hemodiálisis. Doctora de Vriese, please.
Good morning, everybody. First of all, I would like to thank Dr. Alberto Fierro for inviting me to this meeting, which I'm sure I will enjoy very much, and for his warm welcome that we were able to receive yesterday and today. I also like to thank Fernando Fervenza for suggesting my name. If you look in the literature, the goals of dialysis are often described as longer survival, better quality of life, free of dialysis-related complications. But to be honest, when I'm rounding dialysis and I look at the patients, I have the impression that neither in the Middle Ages nor in the 21st century we even come close to achieving these goals. I've been asked to discuss with you today whether perhaps more intensive dialysis regimens like hemodiafiltration, longer and more frequent dialysis may improve the bleak prognosis in our patients. There have been a number of very important trials over the past few years, and I will discuss some of them with you, as well as their pitfalls, which is also very important. First, we will talk about online hemodiafiltration. As you know, 3 large randomized controlled trials have been published over the past 2 years. And this is here a summary of 2 of those 3. You have the contrast trial, which is a Dutch trial, and then the Turkish trial. Both were very similar in design. The main difference was that in the contrast trial, they compared online hemodiafiltration with low-flux hemodialysis, whereas the Turkish trial compared it with high-flux hemodialysis. But for the rest, they were very similar in design, and as you know very well, they were both absolutely negative for the primary outcome parameter, that is total mortality. Now, both trials demonstrated that in a subgroup analysis, those patients that achieved the highest convection volumes had a better survival. This here are the mortality curves, and as you can see very clearly, this is absolutely a negative trial. Importantly, the trial was event-driven, so we cannot blame it for being underpowered as a potential explanation for the negative results. This here is the subgroup analysis for convection volume, and as you can see, the group that achieved here the highest convection volumes, more than 20 liters per session, they had a lower survival. Now, as compared to the other ones that achieved lower convection volumes and as compared to the control group. Now, the authors have performed extensive adjustments for multiple confounding factors in order to exclude a dose-targeting bias. But I think we still have to be very careful in interpreting these results. If you look in the literature, most people interpret the results of this trial as that online hemodiafiltration really improves survival as long as you achieve high convection volumes. I don't think you can interpret it this way. This would be the interpretation if the trial had been designed differently and randomized into 3 different groups: high efficiency hemodiafiltration versus low efficiency hemodiafiltration versus low flux hemodialysis. Then you would be able to conclude this. Now the only thing you can say is that those patients here in this group that achieved high convection volumes have a better prognosis. Now the fundamental question is, why is that the case? So the heart of the matter is, what drives the convection volume? And this here is a preliminary analysis from the authors of the contrast trial that they published a few years earlier, where they looked at convection volume. As you can see, the majority of the patients did not achieve the predefined target that was empirically set at 6 liters an hour, so 24 liters per session. Although the majority of patients did achieve the 17 liters per session that was demonstrated in the DOPS trial to be associated with a better survival. Now, what drives the convection volume? It appears that those patients that had high convection volumes, that they had lower hematocrits, that they had higher albumin rates, but especially they had higher blood flow rates, which is very logical. So the question is, why did they have higher blood flow rates? It's possible, and maybe even likely, that those patients that achieved high blood flow rates did this because they are intrinsically better patients. So patients that accept and achieve the higher blood flow rates also might have baseline characteristics that contribute to their superior outcomes. They may be more compliant also with other healthcare prescriptions, and the quality of the vascular access was not reported in the trial. It could be that their quality of the vascular access was better, and therefore their vascular bed in its entirety was better, and therefore they might have a better prognosis. So it's all very complicated, and the publication of the ASHEL trial last year didn't make it more easy to interpret. Dr. Maduel, Francisco Maduel, who's going to give his talk tomorrow, will explain you more about the ASHEL trial. But basically, the ASHEL trial demonstrated that online hemodiafiltration reduces mortality with 30%. However, if you look carefully at the data, you will see that the devil is in the detail. This is here the table with the baseline characteristics. And if you look at the baseline characteristics in the online hemodiafiltration group, you will see that on average, the patients with 2 years younger, they had a lower prevalence of diabetes, they had a lower Charleston comorbidity score, and importantly, they had a significantly lower prevalence of catheter use as the vascular access. So these differences in baseline characteristics, although I admit they were accounted for in the final statistical analysis, they could perhaps have influenced the survival in this group independently of the effect of online hemodiafiltration. In addition, it appeared that in the online hemodiafiltration group, about 50 patients dropped out because of vascular access problems. None dropped out in the control group. So perhaps the patients that had the lowest quality of vascular access and therefore the lowest quality of vascular bed in its entirety were removed from the analysis. And finally, there was more transplantation in the online hemodiafiltration group. Patients were censored at transplantation. So by definition, they were survivors until transplantation, which may also have influenced the results in favor of a treatment effect. So, well, if we assume then that the results of the ASHEL trial do demonstrate that online hemodiafiltration improves survival and cannot merely be attributed to differences in randomization and in dropout of patients during the trial, then the question is why? Why does online hemodiafiltration improve outcome? Is it because of better removal of middle molecular weight substances, which is the biological plausibility behind the online hemodiafiltration? What argues a little bit against it is that beta-2 microglobulin levels, which we know are a good parameter for middle molecular weight removal, increased in both treatment arms. Now, ASHEL trial did demonstrate a proven benefit of online hemodiafiltration, that is the improved intradialytic hemodynamic stability. As you can see here, the number of symptomatic hypotensive episodes during the trial in the online hemodiafiltration group was significantly lower. It has been demonstrated before that this effect is mediated by cooling. As Professor Locatelli from Italy has demonstrated in his trial a few years ago, the difference in hemodynamic stability disappears when online hemodiafiltration is compared with temperature-controlled hemodialysis. So we know that intradialytic hemodynamic instability is associated with significant long-term harm, like myocardial stunning, gut ischemia, cerebral ischemia. So it may be possible, if you improve this with online hemodiafiltration, whether it's by cooling or by other means, that you can, improve survival to a certain extent. This is here an overview of the European trials that have looked at hemodiafiltration over the past few years. This is the trial by Professor Locatelli. This is here the contrast trial that we've discussed, the Turkish trial, and this is the Eschel trial, about which you will hear more tomorrow by Professor Maduel. And we hope that at least some of the remaining questions might be answered by the publication of the trial of Professor Cano, which was closed a few years ago, but which has not been published so far. Now, I guess the inevitable when there are contradictory results from individual trials is that a meta-analysis is appearing. Although I doubt whether by principle a meta-analysis can solve a question that was not solved by the individual trials themselves. So indeed, last month, the meta-analysis appeared in Seminars of Dialysis. So what they have done is they included here 3 of the older and smaller trials, and then the 3 larger randomized controlled trials that were published in the past 2 years. Now you see here the contrast trial. This is an absolutely negative study with a relative risk of 1. And then here, the trial of Professor Maduel, which demonstrates a difference, a beneficial effect. And this has, influenced the results of the meta-analysis to a large extent. So, well, what can we conclude about online hemodiafiltration? In contrast to the many, publications in the literature, I think as far as I'm concerned, I believe that the benefit at present is still unclear. There appears to be a dose response between convection volume and mortality risk, although we don't know whether this is really a true biological effect or this is a dose targeting bias. On the other hand, there's no evidence that online hemodiafiltration is unsafe. So if you want to do it, I think you can do it safely. You're not harming the patients. And then the question is, why? If it improves survival, why does it improve survival? Is it mediated by cooling? And could we maybe achieve the same effect by just lowering the temperature of the dialysate in our patients? So we don't really know about hemodiafiltration. Perhaps we should dialyze longer or more frequently. The interest in this was generated many years ago by the finding that hemodialysis patients tend to die in the long interdialytic interval. Here you can see the rates of sudden death, of cardiac death in chronic hemodialysis patients. They are much higher on the day following the long interdialytic interval. Here this is for the patients of the Monday, Wednesday, Friday groups, and here for the Tuesday, Thursday, and Saturday groups. In contrast, mortality rates for patients on peritoneal dialysis are distributed evenly throughout the week. These findings were replicated by Foley in his analysis in the New England Journal of Medicine several years ago, where we found that cardiac death, hospitalization for cardiovascular disease, congestive heart failure, dysrhythmias, myocardial infarction, etc., were all much more frequently on the day following the long interdialytic interval. So, taken together, the evidence indicates that the intermittent nature of thrice-weekly hemodialysis may contribute to the morbidity and mortality found in our patients. And perhaps more frequent dialysis could resolve this by eliminating the long interdialytic interval. So a few years back, 2 very important trials have been designed by the Frequent Hemodialysis Network group. There was the first trial in yellow here was the daily in-center trial, where they randomized patients either to thrice weekly conventional in-center hemodialysis, like you and I are doing in the majority of our patients, or 6 times per week in-center hemodialysis, and they've observed the patients throughout 1 year. The other trial was the nocturnal home trial, where they randomized patients either to thrice weekly hemodialysis at home or 6 times per week nocturnal hemodialysis at home. So both trials have been published a few years ago, and these I've copied the results from the New England Journal of Medicine, from KI, and I put them next to one another for comparison. Now, obviously, they couldn't aim for mortality as an endpoint because they were both relatively small trials in a relatively young patient population with a relatively low comorbidity and a relatively short follow-up. So they couldn't aim for mortality. So they had to aim for surrogate markers. You see that the effect on left ventricular hypertrophy and on blood pressure here is consistent. They had a beneficial effect. It was not statistically significant in the nocturnal trial, but this was a power problem. They had a large variation in left ventricular hypertrophy at inclusion, and they had a low inclusion number. So they had a power problem here, and therefore this is not statistically significant. But the trend was there. So an effect on left ventricular hypertrophy and on blood pressure. Obviously, there was also an effect on phosphate clearance. But to many people's surprise, there was no effect on albumin levels and no effect on ESA-dose. In subsequent analysis, they looked at the physical function of the patients. And they did this in an objective way and in a subjective way. So in the subjective way, they questioned patients about their physical health. How do you feel? Do you think you can do more exercise now that you're treated with frequent hemodialysis? How do you feel about your health in general? And the patients in the nocturnal group, they say, not different. The patients in the daily in-center hemodialysis, they reported to feel better, a better physical function. But when they were actually tested, they had to do simple things like sitting on a chair, standing up, walking a little bit on a walking ment, etc. So they were not found to do better in the frequent dialysis groups. And the same was true for cognitive function. So they were subjected to a number of batteries to test cognitive function. This is one of them, the trail-making test, part B. So you basically have to connect the numbers and the letters, 1A, 2B, 3C, etc. I actually took the test myself after a long and exhausting day. And then the next morning, after a cup of coffee, and I did 10 seconds better. So I think it's a good way to test your cognitive function, to test your alertness. Well, look at the results. None of those batteries of tests of cognitive function appeared to be better in the frequent hemodialysis patients. But if the patients were questioned about their cognitive function, about their mental health, about their emotions, in the daily in-center group, they reported better results, while in the nocturnal group, there was no change. So how could you then explain this discrepancy between the objective measurements that were negative and the subjective evaluations by the patients that were better, at least in the frequent in-center dialysis group? Perhaps all the patients, they were well aware of the subject of the trial, about the aims, the biological plausibility. They were well aware about the presumed benefits of frequent hemodialysis, and maybe they reported what they thought was expected from them. Maybe there was a placebo effect, we don't know. I should report one important caveat, however. In the frequent nocturnal trial, they had to include more patients that had still substantial residual renal function at the start, which may also be a reason why the effects were less pronounced in that group, because probably the effects of residual renal function overwhelmed the additional effects of dialysis. So they included more patients that had substantial residual renal function, but what is a little bit frightening, if you ask me, is over the course of the year of follow-up, in the frequent nocturnal group, more patients developed anuria as compared to the conventional hemodialysis. So there's a more rapid loss of residual renal function if you subject patients to frequent long-term hemodialysis. This is a study that was reported a few weeks ago by Michelle Ladunovic, where she demonstrated the effects of intensive dialysis on pregnancy outcomes. It was not a randomized controlled trial, it was registry data. So 22 pregnancies from the Toronto registry were compared with 70 pregnancies from the American registry, and she was able to demonstrate a clear dose response between dialysis length and frequency and pregnancy outcomes. You see, the more intensive the dialysis, the higher the live birth rate and the longer the duration of the pregnancy. So what can we conclude about frequent and longer hemodialysis? There appears to be a consistent effect on cardiac hypertrophy, both structurally and functionally. I haven't demonstrated you the data about the functional benefits, but they were published in NDT this year. Physical and cognitive function appear to improve when patients were questioned about it. Subjectively, they felt better, but not when they were tested objectively. And one important caveat, there was a more rapid loss of residual renal function. So where does this leave us? I mean, we are a number of very important, well-designed trials richer in hemodialysis, but they fail to provide us with the guidance that we as clinical nephrologists so desperately need in the care of our patients. They left us with more questions than they provided answers, and I'm afraid so did I leave you. I'm sorry. Nevertheless, I hope we don't have to wait until eternity in order to find out how we should dialyze our patients. Thank you.
And a very interesting presentation. I'm European, but I work in the United States, and online hemodiafiltration is unknown in my territory. The comment I'd like to make is that the studies were small and lots of problems and residual renal function, all these parameters were not taken into account. And then one of the tools that you used in the studies was a quality of life measurement tool. And as we find, many of these tools have been used in other diseases. For example, the SF-36 has been used and developed in cancer patients, and we've been using it in kidney diseases. And it's not sensitive. So the question is, these studies did not find an effect, but it may be that these tools are just not geared for our patients on dialysis to pick up the effect of improved physical function, improved mental function. Were those tools that were used, were they designed to detect changes in cognitive function for people on dialysis?
Well, I think this is an excellent remark, Marie. Probably, most likely, as they are not specifically designed for patients on dialysis, but still there were a couple of those tests that looked at dialysis-related features. The illness protrusion index, for instance. How do you feel that your disease and your treatment affects your quality of life? So they were specifically designed for dialysis patients. Yes.
I would like to ask you, which technique is better, the control of phosphorus level?
For the control of phosphorus, well, phosphorus it is a small molecule, but it's surrounded by water molecules, so therefore it behaves like a middle molecule in terms of removal. So with online hemodiafiltration, the biological plausibility is that because you have convective removal, that you remove the middle molecules to a larger extent. So with online hemodiafiltration, this is very well demonstrated that your phosphate decreases, and also with prolonged dialysis, the phosphate decreases. But the thing is, how does this translate then in better quality of life, in better survival? There we lack the connection.